Streptococcal infections are caused by any one of the Streptococcus bacteria species. They are gram-positive cocci that cause a series of medical conditions including strep throat, pneumonia, and numerous wound, skin, heart valve, and bloodstream infections. The predominant types which cause this are groups A, B, Streptococcus pneumoniae, and the Streptococcus viridans group. Mainly, they are oxidase and catalase negative and are part of the commensal microbiota of the mouth, skin, intestines, and upper respiratory tract. Common symptoms associated with streptococcal infections in general include a sore throat, fever, chills, tender lymph nodes, scabby sores, rashes, and multiple others depending on the form. In general, most are relatively contagious, and so coughing, sneezing, and direct contact with part infection are all methods of transmission. Strep pneumoniae is commonly known for its role in pneumococcal infections, which can be life-threatening in the young and elderly. They can be present in various parts of the body, usually the lungs, but also the middle ear and sinuses. Tougher infections appear in the blood and the meninges, so symptoms surrounding chest pain, cough, rusty-colored sputum, and drowsiness are associated with pneumococcal pneumonia, while headache, stiff neck, and vomiting are related to the more serious meningococcal infection. Streptococcus viridans, or VGS, is a large group of commensal alpha-hemolytic bacteria which are primarily found in the mouth, gut, and genital region. Pathogenicity is low, but infections can occur when it enters other regions of the body through the bloodstream. Most commonly, VGS is able to induce subacute endocarditis by entering the bloodstream and adhering to fibrin platelet aggregates on heart valves, whether undamaged, previously damaged, or artificial. There, it clings on and does not release, creating a biofilm, causing various cardiovascular symptoms such as heart murmurs due to reduced cardiac output and possible valve erosion. Subacute endocarditis, caused by S. viridans, typically occurs in older patients who have previously damaged heart valves. Specific symptoms include tiredness, weight loss, and night sweats. Other complications include pericarditis, splenomegaly, otitis media, and dental caries, just to mention a few.
This particular case involves a 70-year-old man who was admitted to the medical ward for the investigation of a heart murmur and possible pneumonia. Specifically, a sputum sample, throat swabs, and blood cultures from the patient were collected and analyzed. Once these are received, it is crucial to check the information on the referral form along with the samples that have been provided before any work is carried out to make sure that they match. In the lab setting, part of the first step involves simply observing the appearance of the samples. For example, in the case of the sputum sample, a particular rusty red color could provide a notable indication of the presence of Streptococcus pneumoniae. After this, a gram stain is done for the sputum sample, but not for the throat sample. This is because the intense presence of multiple oral microorganisms would not pinpoint much clinical information from the throat swab. The next step is analyzing what is present in the samples, otherwise known as a culture. With the sputum and the throat samples, each will be plated out on horse blood agar in both aerobic and anaerobic conditions, as well as on McConkey agar. This is because Streptococcus species do not grow on McConkey, and so this can be a quick way to differentiate them from other species that do grow, such as Enterococcus. Growth is observed after a day most commonly, or at least 18 hours for horse blood agar and 24 hours for McConkey. The blood that is collected is inoculated into bottles containing culture media, and then growth is observed daily for around 5 days. If any of the blood cultures are positive, it is important that each one is subcultured and any isolate is identified. A significant further identification test is the optician disc. This is needed to differentiate the growth of Streptococcus pneumoniae and Streptococcus viridans, as they both present the same on media, on the gram stain, and both their catalase and their oxidase tests. Here, Streptococcus pneumoniae presents sensitive, while Streptococcus viridans presents resistant. Usually, Lansford grouping would be carried out for Streptococcus species. However, both suspected organisms are alpha hemolytic, and hence they do not have an identified group. From the lab, the sputum gram stain revealed a surplus of gram-positive cocci and gram-positive rods. However, there were more gram-positive cocci than rods present. Numerous epithelial cells were also present in the sputum sample with an absence of pus cells. A culture of the sputum specimen revealed a mixed equal growth of natural oral flora as well as Streptococcus pneumoniae.
The throat swab exhibited a mixed growth of natural and oral flora, including Streptococcus viridans and Streptococcus pneumoniae. The blood culture revealed a growth of Streptococcus viridans, isolated from 2 out of 6 bottles after 5 days. In the sputum gram stain, the lack of pus cells indicates no immediate signs of infection. The epithelial cells indicate the presence of saliva and possible contamination from the natural oral flora of the mouth and respiratory tract. Since the sample is mostly saliva, the culture of this sample is not a good representation of the pathogen causing the infection, and thus makes it difficult to identify. Another sputum sample should be obtained with the attempt to limit contamination with natural oral flora of the saliva. This possibility of contamination is furthered by the gram-positive cocci and rods, all of which are common gram stains of the natural oral flora. Streptococcus pneumoniae and viridans are confirmed as a naturally occurring bacteria in the throat. Therefore, due to contamination, these specimens collected from the sputum were considered insignificant for diagnosis, and a sample of better quality with less contaminants must be attained. This can be done by collecting a sputum sample straight from the lung in order to avoid the natural flora residing in the mouth. Similarly, the throat swab revealed only a mixed growth of naturally occurring flora in the throat and Streptococcus pneumoniae, which therefore dismisses it as a viable specimen for diagnosis. The blood culture revealed the presence of Streptococcus viridans in 2 out of 6 bottles, which is a significant finding to further investigate, as growth in more than 1 bottle strengthens the clinical value of the finding, as S. viridans is not a commensal of the skin and is therefore not a contaminant. This is indicative of the presence of S. viridans entering the bloodstream and potentially causing infection in the patient's heart valves, a possible cause for the heart murmur. A notable portion of patients, between 30 to 40%, which present with S. viridans, will have subacute endocarditis. In subacute endocarditis, the bacteria clings to the heart valve leaflets, and therefore the presence of S. viridans in the bloodstream used for the blood cultures would be minimum, hence only 2 of 6 bottles being flagged as positive. Thus, from the specimens acquired, Streptococcus viridans is the suspect pathogen, and the blood culture was the most relevant specimen that was collected.
From the results gained from each specimen received from this patient, it was concluded that the cause of the patient's heart murmur and other symptoms was a result of a Streptococcus viridans infection. This diagnosis has been drawn due to the positive blood culture bottles, as studies have found that the Streptococcus viridans bacteria can be responsible for causing heart problems in patients if found in the bloodstream. The other specimens received from the patient were important to determine possible causes for the pneumonia symptoms, but as the sputum showed evidence of contamination due to the epithelial cells and the throat swab only showed normal flora, they were both deemed clinically insignificant. The identification of Streptococcus viridans as the causative organism is significant, as the patient should be treated with antibiotics to reduce their mortality from pneumonia, especially as he is elderly and therefore has a weaker immune system. The fatality rate from 2004 to 2012 for pneumonia caused by Streptococcus in patients aged 65 years or older was 6.1% in Australia. Due to this fatality rate, it is vital that the administration of antibacterial therapy is prompt to increase the probability of a successful treatment outcome. Similarly, a chest x-ray or echocardiogram should be performed to determine the condition of the patient's heart and lungs and the extent of vegetation on the heart valves, and to see if further cardiac monitoring is necessary. In addition to the chest x-ray, a recollection of sputum that is of better quality, meaning little to no epithelial contamination, can further confirm if infection is present in the lungs. Pleural fluid can also be collected in order to test if the Streptococcus viridans is present in the lungs. Prior to treating the patient with antibiotics, a sensitivity test should be conducted to deduce if the strain of Streptococcus viridans the patient has is resistant to the antibiotics normally used to treat this infection. If the strain the patient has is sensitive to the antibiotics, then penicillin can be used to treat this patient successfully. However, if the strain of Streptococcus viridans is resistant, then combination therapy with penicillin, ceftriaxone, and vancomycin can be effective. The dose, length, and combination of these antibiotics is dependent on the degree of resistance, and more detail can be seen in the table. Once treated, the patient should be able to recover, and if there is no lasting damage to the heart valves, then there is no need for surgery. However, if surgery is performed, an excision of the heart valve should be collected and sent for both microbiological and histopathological testing.